Welcome, everyone. Thank you so much for joining us tonight. We have a great program for you in honor of Endometriosis Awareness Month. It is my distinct honor to introduce to you our moderator tonight, Dr. Janice Aubie. Dr. Aubie is a general OB/GYN physician and the medical director of the postpartum service at Morgan Stanley Children's Hospital. She cares for patients across the life course and is particularly passionate lately about improving the fourth trimester for patients and their families. She has a master's degree in public health and is dedicated to improving the experiences of patients, especially those who have been traditionally underserved or marginalized. Dr. Aubie?
Thank you, Lisa, and welcome everyone. I'm so happy to be here tonight and honored to be joined by my fellow panelists. To give you a brief plan, we're going to be introducing our panelists. We'll take some time to do some polls to get a sense of why you all have joined us tonight. And then we will save some time for questions and answers. So hopefully, if you have not had a moment to submit a question in advance, please take a moment to think of questions and add them to the Q&A. We definitely will keep time to review those questions later. But first, let me take a moment to introduce my co-panelists. I'll start with Dr. Jessica Okuku-Anane. She is a gynecologic surgeon, and her practice focuses on patients with endometriosis, fibroids, irregular bleeding, and pelvic pain. She completed her fellowship in advanced minimally invasive gynecologic surgery, and she offers laparoscopic and robotic surgery in 3 office locations in Manhattan and Westchester. She joined Columbia earlier this year from the University of California in San Francisco, and in San Francisco, she was the director of the Endometriosis Center there, and she will be working to create a similar center here at Columbia. She will work to create a center that has multidisciplinary collaborative care models for the care of patients with endometriosis. I'll next share with you Dr. Lauren Bishop. She is a reproductive endocrinologist and infertility specialist here at the Columbia University Fertility Center here in Midtown. Before coming to Columbia, she completed her fellowship training at the National Institutes of Health. Dr. Bishop offers a full range of fertility assessment and care with a special focus on patients with endometriosis, diminished ovarian reserve, and ovulatory disorders. And our final panelist is Dr. Katherine Monk. Dr. Monk is a reproductive psychologist and director of the Women's Mental Health at OB/GYN within the Department of OB/GYN. She is a mental health service provider, and her service is embedded within our Department of OB/GYN. She leads a team of 7 psychologists, social workers, psychiatric nurse practitioners, and they work to support patients within our department. Dr. Monk is a leading NIH-funded researcher, and she focuses on the impact of stress in pregnancy and other areas of women's health. Thank you all for joining us here tonight. Before I start with questions for the panelists, I'd like to take a moment to take a quick poll to see, some of the reasons why the members of our audience have joined us tonight. So our question really is, what's your area of interest? Is it endometriosis generally, getting a diagnosis, surgical care options and expertise, medical management options, fertility considerations, integrative care approaches, or new areas of research? So I know Elisa will share those poll results once they are complete.
Okay, here we are. And it looks like the majority of our audience is interested in endometriosis in general. And then the next most concerning topic was fertility considerations, followed by integrative care approaches And then we are looking for people who are interested in getting a diagnosis, new areas of research, medical management options, and then surgical care options and expertise.
Okay, so let's keep all of those, considerations in mind as we move to questions to our panelists. So I'll start with Dr. Apuko Anane. Jessica, you are someone who, sees patients who may come to you with a diagnosis of endometriosis or suspicion thereof. And in taking care of those patients, there's always a question of, what do I do next? Is the best intervention surgery? Is it medical management? How do you make that decision on what's the best, course of action?
That's a great question. I think, every patient who enters into my office, we do a different treatment plan because how we proceed is really based on the goals of the patient. So for many patients, it's to improve their pain. For other patients, it's fertility. For other patients, it's truly just a diagnosis. And depending on what the goals of care, we modify our treatment options based on that. And in general, for patients with endometriosis, I've found that with our multidisciplinary approach, we're doing some combination of medical management or hormonal suppression to decrease estrogen levels that stimulates endometriosis. We're also doing some surgery with full surgical excision in order to remove any disease that's present. And then sometimes we're integrating some integrated medicine options, some things from treating any mental health, anxiety, and depression that's common with endometriosis, physical therapy, acupuncture, pelvic yoga, many other things that can be helpful to the treatment of endometriosis. And depending on the goals of the patient, we may choose one or two or all three of those options to treat.
Thank you. My next question, I'm actually going to direct to Dr. Bishop. Again, when patients come, many have an objective fertility or questioning what their future fertility may look like and what they need to keep in mind. So Dr. Bishop, how often do you encounter endometriosis as a barrier to fertility for patients who are seeking pregnancy?
Yeah, so in the general population, about 1 in 8 women suffer from infertility. But in women who have endometriosis, about 30 to upwards of 50% of women who have endometriosis have infertility as well. So it's very common, and it can be from a variety of different reasons. One of the major hallmarks of endometriosis is inflammation, and the way that can impact your fertility would be if you have inflammation or scar tissue that can form on the fallopian tubes. And so that can be a big reason why women are unable to achieve a pregnancy naturally and may start to seek fertility treatment. There's been other studies that might suggest that the egg quality in women with endometriosis may not be as good, or maybe the uterus isn't as receptive of a pregnancy. But the good news is that more recent studies have kind of strayed away from this and demonstrated that there may not be as negative of an impact on the egg quality, that the quality is good. And if we need to go through fertility treatment, that these women do very well in terms of the numbers of embryos that they create and the receptivity of the uterus in achieving a pregnancy. So even if you do have difficulties, it's best to just come in for an evaluation, see where we can make improvements and increase your chances of a pregnancy.
Thank you, Lauren. And as we talk about this, we've talked about, management options, we've talked about fertility concerns. So certainly we know that stress is a big issue that may be introduced when considering this diagnosis. So that brings me to Dr. Monk. How does stress play a role in the experience of having endometriosis and getting the right care?
Yeah, another great question. And I want to relate to the poll and say, I think we're all really pleased that the number 3 choice here in terms of what you all are interested in was integrated care, because you can see us all together, and that's really how we work at Columbia, is interdisciplinarily on this topic and thinking about the role of stress with this condition. So to date, what the research seems to suggest is really potentially a bidirectional process, where certainly if you are diagnosed with the condition, it can really be associated with experiences of stress and depression and anxiety. And the reasons why that is for individual women, can be talked about in therapy, but certainly concerns about fertility, disappointment, the worrying that comes of what's going to be next. What does it mean to have this condition? I'm a healthy young person. Why is this happening? But the other direction is also true that, and this has really been shown most powerfully in animal models, that if you have an animal model of endometriosis and you expose that rodent to added stress, you can, and it's really chronic stress, you can see it accelerate the disease condition and particularly the lesions. So there's also the possibility that added stress is going to exacerbate the condition. And stress, we all feel it, particularly what we've all been through with the pandemic. Obviously, some people have been affected more than others, but it's ubiquitous in our lives, and we do have tools for it. A lot of tools to address how to cope with stress, how to manage it better, how to manage anxiety better. And just as Jessica said, we can tailor these kinds of tools to who the individual patient is. Some people really do well with exercise as a way to manage stress, with acupuncture, and other people are more interested in some of the psychological tools that someone such as myself can offer around using cognitive reframe and mindfulness to manage the stress as part of managing this condition.
Thanks, Katherine. I think what comes to mind is, and in speaking with patients, is timing, and that might be a way that we can introduce some stress management, is to give enough information so that patients can plan and understand what are the things they should be thinking of and the timing of when they should be thinking of it. So my question to each of you is, in your respective roles in caring of patients with endometriosis, when is it the appropriate time to speak to someone like yourself, Jessica, with regard to medical management and or surgical management? And then I'll take it to you, Lauren. When should we be thinking about concerns that relate to fertility? And what is the appropriate timing to consider those concerns? And then lastly, Katherine, where do you fit in the spectrum, from the young person who may get this diagnosis at a very young age to someone who's kind of getting it perhaps later and feels like they've got to condense all of this into a short period of time because they feel like fertility their time may be running out. So I'll start with Jessica.
So I think one of the problems with endometriosis is that it's so often poorly diagnosed, or there's a really long delay in diagnosis. There's a little bit of our culture that suggests that women should be able to tolerate pain. And so I would say that if you're having periods that are extremely painful, that inhibit your lifestyle, that make you have to miss work or miss school or have problems with sexual intercourse, have significant impacts on your life, that's actually not normal. And if you're not sure, that's the time to come in to talk to your gynecologist about whether you need to treat those symptoms, because painful periods is the most common symptoms. But endometriosis affects 10% of women. And so there are other times that you will have pain outside of your periods. And if you're having chronic pain for any reason, pelvic pain for any reason, that's the time to start talking to your gynecologist or endometriosis specialist about getting a great diagnosis and whether to consider surgical or medical management.
Great, Lauren. When should my patient who comes to me and says, but what about fertility? When should I sort of decide that it's time to have children or do something to preserve fertility if it may become an issue once I receive that diagnosis of endometriosis?
Yeah, usually after about 6 months of trying, the chance of pregnancy every month is about 20%. So if you kind of take that out to 6 months, then you should have theoretically achieved a pregnancy at that point. And so if you haven't, then that's a good time to come in and at least just start the evaluation. And it doesn't mean that you'd need to start treatment at that point, but sometimes even just knowing everything looks okay, I can keep trying on my own, might provide a little bit of reassurance, a little bit less stress, just knowing that there may not be anything, that needs to be surgically or medically managed at this point. In terms of fertility preservation, they see that a lot as well. And really anytime for that. If you're thinking about delaying childbearing years until your late 30s or even early 40s, late 20s, early 30s is a really good time to come in and start thinking about, is freezing my eggs a good option, since we know that women with endometriosis do have a higher chance of having difficulties achieving pregnancy down the road. Doing fertility preservation like egg freezing can be a really nice option to kind of keep the door open.
Great, thank you, Lauren and Katherine.
Yes, Jessica and Lauren and I really talk about, we'd like to be lockstep in terms of bringing the stress and mental health piece in right away. And so the mental health team in our department is literally down the hall. Now, of course, a lot of that is on, through telehealth right now, which we're really finding is dramatically increasing people's access to getting care and the ease of getting care. But we really are down the hall. So this can be part of treatment from the start, as I think it should be. It's just at a minimum, managing stress as with any kind of disease condition and any kind of, just thinking about fertility and what's going to be the right time for family planning, et cetera. It's great to have an outlet, and we really are here to be part of the treatment plan. So I would say right away.
Thank you all. I think I have the pleasure of having access to you each being a specialist in your respective fields. So that's wonderful. I would like to perhaps go to maybe another poll. So this poll question is really on what is important to you. So for each audience member, we're trying to think from your own perspective, what's important to you in evaluating care? Is it that you feel listened to and respected by your providers? Is it feeling that you can reach your provider when you need to? Is it feeling that you're being treated in an anti-racist environment? Or feel that your providers communicate with each other and are on the same page about your care? And once again, I'll turn to you, Lisa, to share the results when you have them ready.
Absolutely. We just have a few more responses trickling in, so I'll just give everyone another second or two. Oh. Okay, I think everyone, sorry. we're getting such great responses from everyone. I just didn't want to cut them off. Okay. The overwhelming majority highlighted the importance of feeling listened to and respected by their providers, and feeling that they can reach their provider, and feeling that the providers communicate with each other and are on the same page about the care plan. We're very close. And we had a very small response of feeling like they are in an anti-racist environment, which makes me hope that we do an excellent job of making everyone feel supported at all times. So those are wonderful results to see.
Thanks so much for sharing those results. And I think we all can appreciate how important it is for patients to feel listened to. And we as providers hope that we're doing a good job with that. I guess I'll start in the same order and ask questions, again, keeping our poll results in mind. Do the results of the survey reflect what you see in practice, Jessica? And what approach to addressing what is your approach to addressing patients' needs and concerns?
I'm not surprised by the findings at all. I hear consistently from most of my patients that they've had a long journey with endometriosis, and it felt like their symptoms have been ignored, that we as providers have not necessarily provided the best level of care that we could. I think some of that is related to a poor understanding of endometriosis in general, and our education about endometriosis, even in our training programs. And there are ways that we're hoping to improve that with both patient but also provider education with this Columbia Endometriosis Center. I think when I have the advantage of seeing endometriosis every day for 90% of my patients. So I hear the same stories over and over and over again. And I really try to make every patient or believe that I truly do believe their symptoms. I know that that's something that they have to hear. One of the new things that just came out with the current guidelines on endometriosis for globally for providers is that we don't need a laparoscopy necessarily to diagnose endometriosis. And so I will often give people the diagnosis based on their symptoms right then and there at the office. And in my prior institution, I spent a lot of time teaching residents to be able to diagnose based on symptoms and give people the diagnosis because it's important. It's important both for the patient, but also for them to have that diagnosis in their chart so that when they meet other providers, they feel like they're getting listened to and the providers are respecting that they need help. The other things that we're doing as part of our endometriosis center at Columbia is trying to help coordinate care. And so Dr. Monk talked a lot about integrating some of the other services like mental health directly at our first visit. So every patient that comes into our endometriosis center gets a packet of all of our resources, all of the providers in our multidisciplinary network, and information for how to contact those services, as well as we're working to build in a patient navigator who is a one-person contact that the patients can go to should they have problems communicating with the providers. And then finally, our long-term goal is to be able to create a treatment plan that is specifically made to reach out to all of the different providers that a patient might be seeing, formulate those diagnoses and the subsequent design plan for care, and have that to be disseminated back to their primary care doctors. So there's one document that the patient can take with them that says, all of my doctors, all of my providers think that this is how we should manage my endometriosis. And this is a plan that I agree with, and I want to proceed forward so that we're trying to keep people on the same page.
That's amazing. I look forward to that. And Dr. Bishop, Lauren, I'll ask you the same question. How do you think the Columbia University Fertility Center is trying to optimize the experience and outcomes for patients with a diagnosis or suspicion of endometriosis? And I guess based on what Dr. Pukane just shared with us, it is with the diagnosis of endometriosis.
Yeah, I think, it kind of goes back to always finding a physician that you feel very comfortable with, that you can bring all your concerns about, and you don't feel, that you're not being heard. You want to make sure that you're feeling listened to and just, really well understood and just comfortable with that rapport with them. And we really try to individualize the care, whether that means, teeing people up with surgical management. We don't do a lot of our surgeries because we have such excellent minimally invasive surgical surgeons that we work with. So just forming that relationship and getting people to the right place that they need to go to receive the best care that they can. And not everybody needs surgery. So sometimes if it's just medical management, there's a lot of infertility, we have a wide range of different treatments, from less aggressive things like just timing intercourse to working your way up to inseminations or IVF. There's just such a wide range of treatment options. We just really try to individualize it to exactly what you as the patient needs for your family and personal goals.
Thank you. And Dr. Monk, from where you sit as a mental health provider, how important are these considerations for patients feeling like they are getting the care that they need and deserve?
I'm so glad to have an opportunity to answer that and really echo so much of what's already been said. From a mental health perspective, we can actually wear two hats, and it's really our job to do so, and to be very explicit about it. And what I mean is, at times being on the same, we're always going to be on the same page, but saying, look, we know about your care plan with the other providers, and we see you're on board with it, we know about it, talking to people about it, and that's very transparent and it's very collaborative. Our job is also to have the role of saying, what you and I, you being the patient, and I talk about is completely confidential. And if you need to, if you're not feeling heard, just as if you're not feeling heard at work by your colleague or boss, if you're not feeling heard by someone on your care team, I'm going to keep it in the room with you and have the facilitating role of, well, what's getting in the way and how can I support you in finding a way to be heard? And let's think through the things you can do if you need to escalate it. So part of mental health professionals' real commitment to their patient is the confidentiality when it's needed, and then the explicit, okay, here's where I'm talking to the care team. You've given me permission. It's collaborative. We're talking about, and I'm talking with colleagues about your care plan. So we can have both these roles and be very clear about it. And I think really ensure that patients are feeling supported and heard by the entire care team. And this goes for also, frankly, I need to be open and pick up on times when patients are feeling I'm not available and really listen to that.
Thank you, Katherine. I think I have one question that I'd also like to ask before we turn it over to the Q&A. And I remind audience members to please add any questions that you have to the Q&A section. And then I think this kind of goes back to what you each shared about the diagnosis and timing. And we just learned that it no longer needs to be a surgical diagnosis, but yet we are still seeing patients who've had multiple surgeries and perhaps starting to have surgeries before they understand the long-term impact of having that very first surgery and not understanding, the goal and what they would expect. So, I've definitely encountered patients who've had multiple surgeries and are emotionally scarred from having those surgeries and perhaps may have had some interventions that will impact their future fertility. So to each of you, is there anything that you can share in terms of for our audience members to learn about the questions that they should ask, prior to getting surgeries in terms of thinking about long-term goals and trying to get an organized care plan?
Well, I will clarify that there are some people who truly need the diagnosis. They want to know, they want a biopsy, and they want it proven that it is endometriosis. I will do a surgery for that indication. For the vast majority of the patients that I'm doing surgeries for, it's for either fertility or because they're having chronic pain. And that first surgery, as alluded to, is the most important surgery. So I think the biggest thing to ask questions about is making sure that the person who's doing your surgery does these surgeries all the time. It feels very comfortable with being able to remove it from whatever organs that are there, whether it's the bowel or your bladder or really important structures. Because we wrote a review paper on this. If you look at the rates of recurrence of endometriosis after surgery, it's directly correlated with how much endometriosis is removed. So you want to go into a very nice planned surgery with good imaging. In particular, usually places like big academic centers will have MRI protocols that were able to pick up many of the stages of endometriosis a little bit more than some other places. But just a well-planned surgery with a surgeon who does the surgery a lot. I promote full surgical excision rather than burning or blading the endometriosis. And afterwards, thinking about how are you going to prevent it from coming back? So if you're not trying to get pregnant, thinking about using some type of hormonal suppression, This can be birth control methods, or sometimes we use more aggressive medications like Lupron or the newer medication Orilissa, but thinking about how are you going to prevent that from coming back. And then I think the last thing, and that is really helpful to prevent people from needing repeat surgery, is understanding that you have to treat all sources of pain. And many patients with endometriosis also have concurrent pelvic floor dysfunction or hypercontractility of the muscles of the pelvic floor, have underlying nerve pain, have other or nerve entrapment or scar tissue, lots of other things that develop besides the endometriosis of the source of the pain. And if you don't treat each one of those things, the likelihood that you're going to come back with pain is going to be very high, and you're going to keep having multiple surgeries that actually increases the risk of further surgery. And so it is important to be in a place that has things like urologists who can help you if you're having painful bladder syndrome or interstitial cystitis, having GI doctors who can help you with irritable bowel syndrome, because those are really common. It really is a whole body inflammatory disorder, and you really need to be able to treat that whole thing in order to get significant improvement in pain. And we always promote some of the integrative medicine options because they are very good at treating some of those whole body effects. So things like anti-inflammatory diets, acupuncture, pelvic yoga, a lot of those other supplementary things are going to be really helpful in addition to the surgery to prevent you from coming back and needing repeat surgery.
Thank you. And I appreciate you adding in some of the non-surgical interventions that are also important. And Lauren, a patient who comes to you having had multiple surgeries, is there anything from a fertility standpoint that you think patients should be aware of, just to add to what Jessica shared?
Yeah, I would kind of echo that. If you are thinking about needing further surgery, you definitely want to make sure that you're having this with somebody who's very experienced in dealing with endometriosis and what we like to say fertility-sparing surgery. When we think about surgery and fertility, we always have to have a balance, right? We have to say, do the risks of the surgery outweigh the benefits, or vice versa? Do the benefits outweigh the risk? And that's when we should go to proceed with surgery. Because anytime we're working specifically with the ovaries, if you're trying to remove a cyst from the ovary, it can be more challenging to remove just the abnormal tissue, just the cyst. You're going to inevitably be removing some of the normal ovarian tissue. And will that tissue respond as well, potentially to medications for your fertility treatment? And so that's kind of the risk and the benefits that we're always trying to think about.
Can I just add with that? I think it's really important if you are looking for fertility sparing surgery to go to a place where the fertility doctors and the surgeons are talking to each other, because like Dr. Bishop and I have already communicated about patients, it's really helpful to know what the fertility plan is. And oftentimes I will email the fertility doctor and say, this person has cysts in the ovaries. Would you like me to take those cysts out? Or are you worried about how many eggs they have left? Or should we do a staged procedure where, they remove the eggs first and freeze the eggs first, then we do our surgery, and then they go back and implant? These conversations between the two, it does change what we do during surgery and how aggressive I will be during surgery to improve the chances of fertility, if that's the main goal versus pain.
Thank you so much for highlighting that. And Katherine, again, patients who are facing multiple surgeries, what is it that you would add from your perspective?
Yeah, I think although this happens definitely in discussions with providers around doing the surgery, to be sure that the risk benefits are understood, as Lauren described, and that the patient is really understanding. What we on a mental health team can add to this, and again, being there from the start if another surgery is being thought about, is really that the patient has found their voice, giving them room and support to just have any other questions percolate that they haven't had a moment to express. In these situations, there isn't necessarily one right decision. So a right decision, the best decision, is the one that's really had time to be thought about, and as we like to say, processed. So really giving room and support for, what are your thoughts and feelings about it? Did you get to air what you want to air? Do you have additional questions? Do you have time to answer them? What are your worries? Did you get to answer answers about those? So we can really offer that kind of support and also help people with, they may have lingering painful, emotionally painful, and maybe physically painful, also memories of a prior surgery. So how to manage to go through a next surgery based on being rather potentially activated by another surgery, based on past experiences. It can often be really hard to return to something that was physically or emotionally painful before. So we can provide tools for that if the surgery is really the best option.
I think what you've highlighted is really important, Dr. Monk, being that this is so closely tied to, a monthly menstrual cycle, which for many people is a simple event, but yet for patients with endometriosis can be very emotional and in some ways really traumatic. So thank you for adding your perspective. I think at this point, we may want to turn it over and get some questions from our audience members. So I will turn it back to Elisa and see if she can share any questions from the audience.
Thank you so much. Yes, we have some great questions here. We have several about understanding birth control a little bit better. So one of them is how long after stopping birth control pills can endometriosis or cysts develop, and how quickly? I don't know if that's something that varies from patient to patient, or if there's kind of a timeline that we should be mindful of.
That does vary from patient to patient, but generally, sometimes you'll see it within the first 6 months. Rarely, and most people are not getting image continuously, so it may pop up on image because you're having pain 2 years later. But a lot of times we'll see recurrences within the first 6 months.
I think that's a great question. I hear that quite a bit. How long do I have? If I stop my pills or stop my treatment, how long do I have before I'm going to be in pain again? Or how long do I have, to get pregnant? So this may be something that the audience member is sort of contemplating.
The other way, that 50% of people will have recurrence in their pain within 5 years. For some people, that's within the first 6 months, first year, second year. But by the time you get to 5 years, there's a large percentage of people that will have recurrence in their pain.
And when I see patients who sometimes are thinking about potentially doing IVF and they have endometriosis and they're afraid to come off their birth control pills before starting a cycle, sometimes you don't need to have a period before starting a cycle. We can immediately get started with the treatment without having a painful period.
You ladies perfectly read my mind, because that was one of our next questions. So thank you for that. And this patient is also asking, at what point in a woman's life does endometriosis stop progressing, if ever?
Maybe that's a good question for you, Dr. Opukane.
Yes. So generally, endometriosis tends not to be as much of a problem until after menopause. So the average age of menopause is between 50 and 52. And that's because endometriosis is really stimulated by estrogen that's made by the ovaries, and your estrogen production decreases over time after menopause. There is postmenopausal endometriosis, so it can occur afterwards, but it's extremely rare. So for the vast majority of patients, menopause is a time where they no longer need to worry about it.
And is spotting pretty often while you have endometriosis considered normal, or is that generally a cause for concern? I believe they mean between their cycle.
I think I can add that, that may or may not be related to endometriosis. So that would require a full evaluation, because we have other reasons why you may have unscheduled menstrual bleeding that are not related to endometriosis. So this would be something that would be raised with the provider, and a full evaluation, as been suggested earlier, imaging studies, et cetera, to figure out, what direction we'd want to go in. I saw a couple of questions that I wanted to hone in on, which were kind of leading to other activities, exercise, diet. Are there things that someone should keep in mind? Caffeine, exercise. What are the other contributors, or are any of these changes important as a means of relieving endometriosis?
I can also answer that question. Yes. So there's limited data regarding the use. This is included in what we consider integrative medicine. There's limited data for the role of exercise, acupuncture, yoga, dietary changes. Not because these things don't work, but because there are not a lot of people who have studied it. I will say that in my experience of seeing thousands now of endometriosis patients, a lot of patients do have some type of improvement with these measures, and anything that really decreases inflammation, which is what most of these interventions are geared at doing, seems to be helpful for endometriosis.
Perfect. And then we have another question here. Someone is letting us know that they had stage 4 endometriosis, and it was highly suggested or recommended to do a hysterectomy. Is that often a better option to consider, or should they opt into a possible third surgery? Of course, this may be patient specific, but I guess, is there kind of an overall timeline of when certain things make more sense than others?
So the data shows that, again, the more you take out, yes, the chances of your endometriosis coming back decreases. The way that I like to think about it is, if you just remove the endometriosis, the chances of it coming back and your pain coming back are roughly about 40%. If you remove the endometriosis plus the uterus, the chances of it coming back are roughly about 20%. So it decreases by half. And if you take out the ovaries, then the chances of it coming back are closer to 6%. But that doesn't mean that for most of our patients, I recommend a hysterectomy. I think there are other ways to manage endometriosis associated pain besides surgery. So usually I will combine things. So for patients who want to get pregnant in the future, I won't offer a hysterectomy. That's usually one of the first questions I ask, or what are your fertility goals? And if you want to get pregnant, even if you do have endometriosis or adenomyosis, which we can think about as endometriosis inside the uterus, there are other options. Particularly for adenomyosis, there are presechonorectomies, which is a surgical procedure where we cut off the nerves that supply the uterus, or hypogastric nerve blocks, which are where the interventional pain doctors inject some numbing medication into the nerves that supply the uterus. So there are ways to get around having to do a hysterectomy for patients who desire future fertility. There are patients also who desire just to keep their uterus, even if they're not choosing to have children in the future. And that's also a reason to not do a hysterectomy. Although I think, again, if you do the hysterectomy, the chance of the pain coming back are less.
And are there any blood tests available that can diagnose endometriosis without having to do an invasive laparoscopy? And if so, can you let them know the name of it?
There's a blood test that we can do to diagnose endometriosis, but like we alluded to earlier, that you don't need to have surgery to say you have endometriosis. Yes, to definitively give you an answer, you would need to have that pathology from the surgery, but you don't need to have that in order to start intervention in terms of treatment of medications and things like that.
Lauren, that's actually a great point, and I think it was made more than once. But in reading through some of the questions, I think there is a question of how is the diagnosis made then? If you don't need that surgery, what are the criteria that someone needs in order to be diagnosed with endometriosis?
So a lot of it is symptoms similar to pain. So very painful menstrual cycles, and like it can be debilitating to the point where you can't get out of bed, you can't function, you can't do your normal daily activities. Pain even prior to getting your period or right after your period. Sometimes women have cysts that can cause pain even more frequently than that. And then on physical exam, there are some exam techniques that we can use, and we can be more likely to diagnose endometriosis as well. But really the hallmark sign is going to be pain.
And I think the reason why there's a little bit of a confusion is because it takes a little time to ask the questions correctly in order to elicit whether the pain is really cyclic. That's what we're kind of mentioning. But there are very few things that cause cyclic pelvic pain. So it doesn't even have to be with the period, it could be before, as Dr. Bishop mentioned, or it could be with ovulation. But cyclic pelvic pain is a really strong marker for endometriosis. And there are situations that can mask the fact that someone might have cyclic pelvic pain or in the past had cyclic pelvic pain if they're on birth control or hormonal birth control, or if they've been pregnant and breastfeeding. So it just takes the extra couple of questions. That one of the common things that patients will say is, my pain, I never had this pain until I had my last child. It just takes a couple more questions to say, well, how many children have you had? And did you breastfeed? Because you probably had 2 to 3 years of relief with every child. So if you have 3 kids, that's a decade of relief in your pain possibly. And that would be the reason why all of a sudden you're having this cyclic pelvic pain. So cyclic pelvic pain, very strong indicator of endometriosis. When it's not cyclic, it's a little bit more challenging. But especially for most of the patients that are coming into our center, a lot of people have already had other tests to rule out other causes of the pelvic pain. And so common things being common, it's 1 in 10 patients or our patients, we can give that diagnosis without necessarily needing to do surgery.
So I hear you saying it takes a lot of time, and I think in reading through some of the questions, there's frustration that patients experience in the time it takes to reach that diagnosis. So other than having a highly skilled provider who does this every day and is, committed to it and taking the time, I'm going to turn to Dr. Monk. Is how does a patient navigate the frustration that they feel when they have a provider who may not be as responsive to the questions that they ask, or a patient who doesn't necessarily identify as female, but has ovaries and has this experience of pain, and therefore that aspect may be hindering some of the communication that they're having about what we have learned about, which is cyclic pelvic pain.
Thanks for highlighting that very much. I think it's so important to, this is where a mental health provider can come in to be, and this does happen, where we're listening, and it may not be directly what the patient may be, concerned, I'm not getting the answers I want, I'm really not feeling good, but then they kind of move away from it. My job is stressful, or my relationship, and our ears perk up. And we're going to want to hear more, say more about that. We can, we're almost playing a devil's advocate. Wait a minute, this may be something. We're kind of helping them with their confidence, again, to find that voice, and to, help them that what they're experiencing is really important and deserves attention. And this does dovetail with a lot of mental health work. For example, people who have any kind of trauma history, or just come from a home without a lot of love and support and validation, not having their pain experiences responded to by a medical professional who is, there is a feeling of a hierarchy. We all feel a little childlike with our healthcare providers. We want them to take care of us, and we look up to them for their knowledge and expertise. It can really bring up some of these childhood experiences. So again, our ears are perked up. We learn about people's past as part of the work that we do. And we may say, wait a minute, this is, maybe you need a second opinion or to find a voice with this person, because this is making me feel like what you told me, that you just stopped asking your mother for help around this issue. I'm hearing some repetition here. So it really is our job to hear about how they're not getting heard and if they're ignoring their own not getting heard. And then I think with people with different gender identities, it's very, very important that we are a place and people to go to talk about, again, how to find their voice, even sometimes coaching a strategy around words to use to feel comfortable, to find the right provider. But let me then flip for a minute, and flip meaning to the side of being on an integrated team throughout our department. All of us talk with each other about how to be really respectful to the range of patients with whom we interact and for whom we take with whom we take care of, work with them. You know, we help each other with how to listen well and be responsive to individual differences, and we're going to keep doing that. So we can learn from each other. So when I say flip, I'm moving away from the patient and just what we do as providers as well, to keep on educating ourselves and be attuned to all these important individual differences.
Sorry, Lauren and Jessica, anything else that you would add for the patient who, in terms of gender identification, may not identify as female, but has the same experiences? I think, Jessica, you're still on mute.
I think this patient population is one of our very underserved populations, mostly because there's not a lot of research about how to manage patients. And so I would say it probably makes sense to go to a place where you're going to specialized service, because they're going to see more patients who are in similar situations. There are a lot of things that come up with for patients who are on testosterone supplementation. There are a lot of questions there about how you manage the medications as well. But I think for all patients, for our patients, transgender patients, for our underrepresented minorities, or people of color, and for adolescents, those three populations in particular who are experiencing some of the worst issues with our medical system in terms of endometriosis, it's important to shop around. You know, if you're not getting the answers that you need to get, try advocating for yourself. And if you can't find a provider who's listening to you, go to another provider, because there are different options. And in my personal experience, I find that more affluent patients with more resources, they shop around all the time. They're reading online, they're coming with their questions, they're demanding their care. And my hope is that all patients would have the same level of information coming into their visit, would feel just as empowered to ask their providers the questions that they really want the answers to, and are feeling like they're making the decision together with their provider rather than being told what to do.
Thank you. I have a question that I saw that comes in a yes, no, and I think perhaps Dr. Bishop, you can answer. Is endometriosis genetic?
So endometriosis, we don't know an actual genetic, there's no gene that we can identify as this is the endometriosis gene, but we do see that endometriosis does often run in families. So it is common, you know, to hear my mom had endometriosis, now I have endometriosis. So we don't know exactly what the cause is, but it is common that it does run in families.
Does it put you at risk for cancer?
There is a slighter, some studies can suggest there could be a slighter increased risk of ovarian cancer, but this is not a dramatically increased risk.
And then the last one that I saw that's in the same vein is it autoimmune?
No, I'm not aware of any autoimmune conditions that we're able to say are causing endometriosis.
All right. Elisa, I'm going to go back and scroll through the questions. Do you have one that you have ready to go?
Absolutely. We have another one here about diet regarding eliminating gluten and dairy from the diet and its impact on the likelihood of endometriosis returning?
I don't think we know the answer to that. I commonly recommend what you're describing as an anti-inflammatory diet. And usually what that means is it's kind of like a gluten-free diet. It's pretty much a vegan, gluten-free, low estrogen diet. It hasn't been studied enough for us to know if it prevents the recurrence of endometriosis. I would say that I think it's very helpful for patients and help improve the symptoms. And for people who are able to do it very strictly, I've seen good results. I haven't, for people that have like stage 4 disease, I've never seen it reverse endometriosis down to stage 1, but I do think it probably helps people to not come back and need repeat surgery as fast. But again, there's no real clear literature that can guide us. There are some studies about certain supplements and anti-inflammatory things like turmeric and other things that might be helpful as well, but we don't have enough research, which is a really big problem in endometriosis.
There are a few questions about timing of surgeries and whether or not the surgery itself can compromise fertility. So I think we touched on a little bit about timing, but what concerns can you share in terms of the impact of the surgery itself on fertility?
So I think we touched a little bit about this. Whenever you're doing any sort of surgery, specifically to the ovaries, there's always a chance that you could damage a little bit of the normal ovarian tissue. And then that tissue may not respond as well if you, for instance, were to need IVF, where we're trying to get as much of the ovary to respond to the medications as possible. So that's why going back to that kind of risk benefit analysis there, is the benefit of surgery going to outweigh that risk?
We have another question here. Can you explain the connection with pelvic floor issues, constipation, and endometriosis?
I can take that question. Yes. So pelvic floor hypercontractility, or sometimes we call it pelvic floor dysfunction, or sometimes we'll call it things like myofascial pain. It develops for people who have chronic pain in the pelvis from any indication or any reason. In this case, in endometriosis is really common because you just have pain all the time. And what tends to happen is that you clench the muscles of the pelvic floor over and over and over again. Then over time, they no longer relax on their own, or they spasm on their own, and they start to cause pain themselves. And this dysfunction of those muscles of the pelvic floor, which are related to your ability to have a bowel movement, can be why some people will develop constipation as well, and or the medications that we're often using to treat the pain associated with endometriosis. And then the last thing is surgery. So surgery also causes a significant inflammation or pain in the pelvis. And so multiple surgeries can also make that worse.
So I think as a panel, you represent many of the disciplines that are involved in the care of these patients. And I think this discussion highlighted that collaborative care really well. I noticed a question about, what resources are available to patients who may have limited insurance or no insurance. What are the things that group of patients may have available to them, either through our fertility center, or what recommendations can we have for those patients? And I'll start with Dr. Monk.
So for mental health in our department, our service takes most insurances, most commercial insurances, and that's for most of you who know, it's really difficult to get mental health covered by commercial insurances. So we have that box checked off, and that's really important to us. In terms of people who use Medicaid as an insurance, we are working very actively to increase our team who provides that kind of mental health care. That's actively going on. And we do see some people with what we call pro bono, where we're able to see them for an extremely nominal fee in order to have their needs met. So on the one hand, we want to be doing better. It's not fully where we want to be, but we also feel good that we are dramatically increasing access to mental health care, particularly by taking insurance, which is so rare, especially in New York City.
Thanks, Katherine. And Lauren?
Yeah, in terms of fertility wise, COVID did put a little bit of a damper on some of our treatment options, but we did recently reopen one of our centers uptown at the hospital that will start to see patients who may have Medicaid that isn't accepted at our regular fertility center.
Thank you. Thank you for making fertility care available. And Jessica, what suggestions do you have?
For surgical care, I believe that we have the Audubon Clinic, which serves patients with Medicaid, and the surgeons are actually the same as the patients who don't have Medicaid. And then I think we really emphasize a lot of treatments that patients can do on their own. And so I think integrating patients with services that are out in the community that are not as expensive can often be helpful as well. This is always a challenge, and so many of us on this panel are part of our Office of Diversity, Equity, Inclusion. It's one of the things that we're actively working on at Columbia to make sure that we can provide more equitable services to everybody, irrespective of their insurance status or income.
So I know that we are just about at time, and I don't want to keep everyone too late. We had so many questions, and I'm sorry that we couldn't get to them all, but I do want to let everyone who attended this webinar know that we will be sending around a recording as soon as possible, as well as links to everyone's pages. If anyone has any interest in making an appointment or any difficulty, they can absolutely email me directly. The email will be coming from me, and I can help connect you with whomever you need and help you make appointments. And again, thank you so much for all of your expertise, your wonderful answers to everything. It's so clear that there is such a need and that women are extremely frustrated and are looking for guidance and help. And thank you so much for providing that. The four of you were absolutely wonderful. And again, we look forward to hearing more from all of you. Thank you so much, everyone. Have a wonderful evening, and we will be in touch soon. Have a great night.
Good night.